Hi, my name is Anu, and I'm excited to talk about this project of ours, improving access to postnatal contraception during COVID in Wrexham, Myla. And I'm grateful for this opportunity. And I want to talk about this project not only because it's our project, but because it empowers women to make informed decisions about their body. So, first of all, why did we embark on the project? So, in the UK, 1 in 3 pregnancies end in termination. And evidence during the pandemic shows that there was a potential increase. And making a decision to terminate is difficult in most cases, and this can have a negative impact on mental health. 1 in 3 pregnancies that continue were unplanned or unintended, and this raises the concern that high-risk women do not get the preconception care that they require. 1 in 13 women who fall pregnant have conceived within a year of a previous birth, and this is associated with risks. If there's a short interpregnancy interval, these are the risks associated with that pregnancy, and it includes even neonatal death. So there are a number of documents that recommend that women should receive contraception before they leave the place of delivery. One of such is the NICE safety standard, RCOG best practice paper from the Faculty of Sexual and Reproductive Health, and also a joint paper, and they all outline the same, that women should be offered contraception before they leave the place of delivery. So before we implemented the changes, we carried out an initial survey to assess knowledge, attitude, and to help inform what we're going to do. So first of all, we had a survey of our staff, and 97% of them felt that they will benefit from regular teaching. We also sent out a survey to women, and 50% of them did not recall having discussion about contraception either antenatally or immediately after delivery of their baby. And 67% of the staff said they were not aware of where to discuss this discussion when they had it antenatally. And when we did an audit and looked at the notes, we found out that 88% of the notes showed no record, no documentation of contraception, of this discussion on contraception. And during the period of the audit, only 1 woman was discharged home with contraception in the form of sterilization. So we set out on our project. There were 3 phases to the project. The first was staff education. 30 of our staff volunteered to be champions. These are their pictures, and each one of them got a badge that they proudly wore. And our team of champions included doctors of all grades, midwives, healthcare assistants, a pharmacist, and 2 admin staff. Now, all the clinical staff in our team of champions had to complete an e-learning package and then a half-day training session. And then a presentation was made available to them, standardized presentation. And they were advised to change the style of the presentation to suit them if they so desired. But then every week there were 2 sessions, either virtually or face-to-face, for the rest of the clinical staff in the department to get their training. The second part of the project was to provide information to the patients. Now, the information leaflets we're using were purchased from the Faculty of Sexual and Reproductive Health at a cost of 20p per leaflet. So to avoid this cost, we developed our own information leaflet with input from stakeholders, so from our women, from staff, after completing local governance requirements. And we made this leaflet available in Welsh, English, and Polish. Polish because this is the 2nd most commonly spoken language in Wales. Developing our own leaflet gave us potential cost saving of £1,000 per year. Now, the third part of our project was actually delivering the contraception. So we developed pro formas, we put them in files, colorful files, as you can see, and we placed these files in wards and in clinics, such that when a woman after delivery of her baby, she was offered contraception, whichever form she accepted. This was written on the pro forma. The pro forma was sent to the GP so that there will be continuity in the provision of the contraception and also the woman's birth summary. So usually the postnatal check, it's a double slot with the GP to allow for time to discuss contraception. But because we've initiated contraception from the hospital, this potentially meant the GP only needed a single slot appointment for the postnatal check, and that brings potential cost savings to the NHS. Now, overall, looking at the results of our project, so within a 14-week period, we delivered the training, and 90% of our clinical staff have been trained. This chart shows that it was a team effort. So all of our champions had sessions that they delivered the training, and it wasn't just one or two people who delivered the training. The presentation that we use has gone through 4 PDSA cycles. So the version we're on now is version 5, and this just allows for quality and improvement. The training that we delivered to the midwives contains the same information that is available in a course that the Faculty of Sexual and Reproductive Health provide. And this course costs about £60 per person. But because we've been able to deliver the same information, we've potentially saved £7,440 by giving this information to our midwives. And we're waiting for approval or accreditation from the Royal College of Midwives so that the midwives can have this certification as part of their competencies. So after the training, all our staff, 100% of our staff felt that they understood contraception better. 98% felt they were more confident about counseling women, and we offered further training for the staff who didn't feel still feel comfortable with counseling women on contraception. So the third part of our project, looking at the uptake of contraception, you can see that in June, less than 1% of our ladies went home with contraception. In August, we presented our audit findings, and you can see that in September, there was a slight increase in the uptake. By December, 50% of staff had been trained. In January, we had produced the leaflets and the proformas, and this you can see its effect in February, where there was a huge uptake in postnatal contraception. You can see that in March and May there have been dips, and this is one of the challenges that we face. So having that momentum, getting our champions going, ensuring that our staff members are always discussing contraception with our ladies. And apart from that, there has been talk that contraception could negatively impact on breastfeeding. This is one of the things we address when we counsel women, giving them the evidence that it's safe and that they can have this contraception. We were hoping to roll out insertion of intrauterine contraceptive devices immediately after vaginal delivery. We haven't been able to roll out the training program yet, but it is in the pipeline, and we're hopeful that in the near future we'll be able to do this. At the same time, we're developing a mobile application so that women can have this information on their smartphones. It's taking a bit longer than we anticipated, but we're moving forward and making progress, and soon the app should be available for women to download and utilize. So in the future, our plans are to spread and scale. So into the other 2 hospitals in a local health board. We've already identified project leads and champions. We've had our initial meeting, and we plan on rolling this out to the rest of the health board. So with respect to the insertion of intrauterine contraceptive device, we've put the program together, we've put up the standard operating procedure, we've put a business case together. So we're working towards rolling out this project. So this is in the future, and you can watch this space. So our experience as Bevan Exemplars and with this project, it has been hard work, but it has been fulfilling. So looking back, we're proud of all that we've achieved in such a short time. And this we couldn't have accomplished without the support of the Bevan Commission. And yes, it has been rewarding to hear women satisfied that they have access to postnatal contraception, and we've had support throughout. All that we've accomplished has been spectacular, and we couldn't have done it on our own. So First of all, I'd like to say a big thank you to members of my team. So to Dr. Hack, Dr. Kaludi, and Dr. Roberts, they've been absolutely fantastic. And our team of champions, really, we couldn't have done this without them. They've been excellent. And also to the sexual health team, senior management has given us all the support we require. And even to pharmacy, they've been excellent. And last but not least, to the Bevan Commission, really a project has taken off because of your support. So thank you once again. Thank you. Any questions?
We will now have a Q&A discussion. How have you found the impact of training such a wide range of staff?
So with respect to the champions, in maternity, healthcare assistants work quite closely with the midwives in looking after the women, and they carry out general discussions with the women and talk about breastfeeding. So they have a place in care to the women. So it just followed that we could include them in the project. And interestingly, they approached us to say they wanted the training so they could talk with the patients as well. And because there's a lot of paperwork that is generated, we needed help with making sure our proformas, leaflets, all of them get to the right place at the right time. And so having administrative staff was very helpful. And with respect to the training, it was the clinical staff who went on the training because they're the ones who deliver the counseling. Healthcare assistants just help to spread the word more, to encourage the women to ask for contraception before they leave the hospital. Anything else you want to add, Noreen?
Yeah, so I was just going to say that when we were doing our teaching sessions, it wasn't that midwives were taught on a session together and healthcare's on a session together. Everybody was mixed, and you would have, maybe a healthcare or a midwife teaching some consultants and doctors, because the presentation was really standardized and it was kept very basic. So what they should be having, what they shouldn't be having, what to look out for, and we gave plenty of time for them to ask questions. So, and we did have midwife, when the midwives were teaching the doctors, they were getting quite worried about, oh, we're teaching doctors, and we're like, well, everybody's in the same boat as you, because we've done our survey and it shows that everybody wants this training. And those that were a bit worried, so our healthcare support workers that were doing the presentations and were nervous, because as doctors, we present all the time and we become quite used to it. Whereas midwives and healthcare support workers don't tend to. And they coupled up together to provide each other with some support. And then sometimes one of us would log in just to give them that backup. Really, so we just really give them lots of support, and it was all fine in the end.
Based on your learning, what tips and tricks would you offer other teams on this subject?
So I think the first thing is letting women know that it's normal for us to offer contraception and it should be a normal thing. And I think one of the problems was that, oh, well, because one of the questions we asked our women was, are you expecting to leave the unit with contraception? And I can't remember the percentage off the top of my head, but there was a massive number of them weren't expecting to go home with contraception. And that's what we said. That's the mentality that we need to change. We need to let the women know that you can take the contraception from us, and as long as you start it before day 21, if it's the pill, then you're going to be covered after having the baby, and you're not going to have to take any extra precautions. So I think it was giving the women the information that yes, you should be expecting to leave with contraception. The other thing that we explained to them, a lot of women aren't aware of the risks of having, children within a 12-month period. And even more so importantly, if they've had a cesarean section, and we know our cesarean section rate is so much higher than it used to be. So if we go back, if I talk to some of the older consultants and the older midwives, they will say, there was a time everybody got contraception before they left, and then we kind of parted ways from sexual health. And then because of COVID, we're trying to bring it back together again. So yeah, letting women know that yes, it's a normal thing for you to be leaving the hospital with contraception. We're not trying to do anything special. We're just trying to follow guidance. That these are all the safe options for you to use. If you don't want contraception, that is absolutely fine as well. But just understand that you are able to get pregnant and what the risks involve. And that, with COVID, not having that postnatal check has meant they've not been able to get the contraception they want. So not being able to have the depot as planned, or have coils put in as planned. So as Anu was saying, we're planning to put them in after vaginal deliveries, but we have started to put them in after cesarean sections. And at the moment, everybody, on our list, there'll be one patient that is having a coil put in at the time of cesarean section, which, is more than what we were doing when we first started all of them. And it means that they're not having to wait on a list for ages to get a coil put in. And that's about it, really. I think just making sure there's plenty of information for women and the staff are confident to answer questions.
What advice would you give the next generation of Bevan exemplars?
I think getting stakeholders on. So having that support from senior management team. It was great having pharmacy on board. So we had that information that we needed straight away, and getting the staff involved as well. I think one of the reasons why the project took off the way it did is because of our champions, because they were enthusiastic about it, even more so than ourselves, and they were happy to take this forward. So having that engagement with the staff, senior management team, and as I mentioned before, really having Bevan Commission, saying that the work was supported by Bevan Commission opened lots of doors and pretty quickly. So these were key factors in the success that we've seen so far.
Could you tell us a little bit more about your app?
Okay, so it's all about information, and we know that our ladies in the antenatal clinic, they get lots of leaflets, and we know how it is with leaflets. You can misplace them or you won't read them. And when we carried out the initial survey, we also looked at the usability of QR codes to access surveys, and based on that, we looked at having QR code to take you to an app where you have all that information. So at this point, the app is in the testing phase. We're hoping that by now it will be available on Android and Apple Play Store, but hopefully by the end of the week, yes, it will be. So it's just basic information about the different forms of contraception available, and then there'll be a contact information to maternity services if patients wanted more information. And on our leaflet, on our poster, there will be a QR code that will take patients to that app. At this particular point, the QR code we have on our leaflet takes our patients to SexWise website for more information, but we're hoping that once the app is ready and we're able to download it, we can put the QR code on. So it was just to get information at fingertips for patients, easy to read, easy to scroll through. These are the options, these are things to look out for. So that's why we thought, let's get on with the app. And yeah, she'll be out by the end of this week, hopefully.